Oh, good morning, good afternoon, good evening, everyone. Welcome those who are live, but also those who might be watching this on recording to our latest Data for Nutrition webinar. And as we're committed to addressing the entire nutrition data value chain, today we're going to focus in on some of the details around analytics and have a presentation on analytical methods to identify drivers of change in population level nutrition outcomes, looking at multivariable decomposition approaches. Next slide. So just a couple housekeeping issues before we start. So we keep all participant video and microphones muted during the presentations. And so we ask that you use that Q&A button to submit your questions to the speaker or to the panelist. And feel free to put a question in there at any time, and we'll get to as many questions as we have. We actually ask that you reserve the chat button over on the left to deal more with internal or any sort of technological issues. So really use that Q&A button. A recording of this webinar will be available on the Data for Nutrition YouTube channel immediately. And the presentations and a Q&A summary will be posted in the community in the coming week. Next slide. If you're having any trouble, technology, if you can't hear, please use that chat window and select all panelists, and we'll be able to do the best we can to respond to you during the webinar. Next slide. So today's webinar is hosted by the Data for Nutrition Community of Practice. Data for Nutrition provides members with opportunities to share knowledge, experience, and questions related to strengthening the nutrition data value chain at all levels in order to achieve better nutritional outcomes in low and middle income countries. We are always welcoming more members, but we're also welcoming our members and others to use this as a platform to share your work. So please do reach out if there's something you're interested in featuring. So today I'd like to introduce you to today's moderator. Goutham Kandru is an associate director on the Exemplars in Global Health program of the Gates Ventures, which is the private office of Mr. Bill Gates. There he serves as the topic lead managing the nutrition portfolio, which examines positive outliers in stunting and anemia among women of reproductive age. In addition to guiding research scope and execution, Mr. Kandru works in tandem with global and country researchers to deliver key findings to Mr. Bill Gates and other decision makers who are interested in order to inform funding and policy making. So welcome, Goutham. We're thankful to have you.
Yeah, absolutely. Happy to be here. And then I guess just in terms of introductions beyond myself, we're joined by Nadia today, who's leading the charge on walking us through the technical details of this approach and methodologically what we're digging into. I don't know, Rebecca, if you want to do the specific introduction, but have worked closely with Nadia as we've applied this approach to our exemplar specific work. And excited to dig into that over the course of this discussion today.
Okay, so yes, Nadia Akseer is a epidemiologist biostatistician with more of a decade of experience. She's extensively published in papers related to women and children's health. She has a passion in particular for Afghanistan, but has done work across low and middle income countries. And she's my colleague, actually, another faculty member at the Johns Hopkins Bloomberg School of Public Health, but she also plays a special role as a scientific advisor to the Exemplars initiative. So welcome, Nadia.
Great to be here. And hi, everyone. I'm excited to dig into some of the content today.
So I'll hand over to our moderator. Go ahead.
Sounds good. All right. So maybe before we dig in, just starting with a few opening remarks and providing a bit of context for why we're looking at this particular type of analysis and what it meant in terms of the broader sort of portfolio of research within the Exemplars sort of initiative. So let's start with the premise of the work itself, which was really about trying to understand the value of looking at positive outliers. And so when we're digging into sort of the unique value of understanding positive deviants or positive outliers, this approach was one component of a broader sort of mixed methods approach to really unpack beyond sort of a standard analysis to understand what went wrong. Really try to unpack four instances or geographies and outcomes of interest around nutritional outcomes like stunting, for example, what's really driving change? And you know, to these sort of subcritical questions underneath that for drivers of stunting reduction. You know, what is the relative contribution of all these things that we know matter to stunting? And in what sort of rank order priority should we as policy decision makers or data analysts be thinking about sort of decision making in that sphere? And so as we're thinking about how we tackle these questions from a quantitative perspective, this is sort of one tool that we've examined and leaned on quite heavily in order to begin to shape sort of data outcomes in a way that'll be helpful for policy and decision makers to shape their strategies to reduce stunting. So on the next slide here, maybe just a little bit more context around the work itself and how we select some of these positive deviants as part of the Exemplars sort of broader portfolio. The definition for outliers or sort of exemplary performance in this case was a sort of cross-sectional view of, you know, reduction of stunting prevalence versus GDP per capita growth. So really what we're talking about when we're talking about outliers in low and middle income countries is understanding, you know, against sort of relative GDP change over a set period of time over the past 15 to 20 years, are there countries that have reduced their stunting burden over and above what you might expect? And then within that sort of subset of countries, the short list we're seeing on the far left here, ranging from El Salvador to Vietnam, you know, within those subset of countries, are there specific instances that we want to dig into from a research feasibility perspective, where data and sort of evidence permits, to begin to understand why that change occurred? So that was something we had tackled as part of this first phase of work. And so the first 5 countries that we dug into, we're seeing on the far right here: Peru, Ethiopia, Senegal, Nepal, and the Kyrgyz Republic, in coordination with a broader sort of technical advisory group. And so all this to say, you know, when we're talking about selecting countries and conducting this mixed methods work, we're talking about, of course, a literature review, a number of quantitative analyses, and then a few different components as well, which as we click through the slide, we'll dig into on the qualitative side for policy program finance reviews as well. And then finally synthesizing all of this information. So all this to say, this larger initiative is a truly mixed methods approach. But when we're thinking about the quantitative analysis in particular, one major component that's helped us sort of organize a lot of this information into a sort of useful framework and begin to sort of unpack the various contribution of drivers is the Oaxaca blinder decomposition. And so this is sort of the focus of today's discussion. And with that, I'll kick it over to Nadia to dig into sort of the thought behind why we use this specific analysis in particular, and then a little bit more into how we go about conducting it. So over to you, Nadia.
Thank you, Goutham. Okay. So I wanted to start off with a little bit of background on this methodology. So what is the Oaxaca blinder decomposition? This is a counterfactual decomposition technique, which is typically known as in the literature. It was originally designed to study mean differences between 2 groups, 2 exposures. It was popularized by Blinder in Oaxaca in 1973, and then later coined the Oaxaca blinder decomposition. Nowadays, it's just called decomposition, and there are many different forms of it. You know, you may have heard of Oaxaca blinder, and that's kind of how it's commonly referred. So the general way of applying this method is to try to take the differences between 2 groups and break them down into what is explainable, you know, in terms of measured covariates or measured factors between the 2 groups, and then what is left unexplained. And this can be applied for 2 groups, for instance, the way it was initially used to look at ethnic subgroups in the USA and to understand what are the differences in wage between these ethnic subgroups, or it can be used in, you know, looking at differences over time, which is the way that we've implemented it in the Exemplars work. Since then, since 1973, this method has become quite popular among econometricians and especially epidemiologists working in nutrition. If you do a quick Google search on Oaxaca blind or decomposition in nutrition, you will retrieve or hit thousands of studies that have used this approach, and again, in various adaptations of it. Some of the types of studies where it's been used, they've looked at racial and gender disparities in obesity in India, for instance, looking at regional inequalities in child stunting in North Africa, looking at urban-rural differences in children's dietary intake in Ethiopia, and the list goes on. So the idea is if you have two groups, whether the groups are two exposure groups or over time, and you want to understand, okay, what is accounting for the difference in some key outcome between these two groups or over time, and want to understand the drivers and determinants between those, you could apply this methodology to do that. So we've done this for the stunting exemplars work, and our work has been published in a supplement. This is the supplement cover page. There are 9 papers here. In one of the papers, we dig deeper into the methodology. So you can find this online. It was published in the AJCN journal. So here we talk about the mixed methods approach overall that Goutham shared a little bit about, but also we go into detail on the decomposition analyses and how it was applied across the suite of, or the selection of case studies. And then we also have country papers. And so I'm showing the cover page here for our Ethiopia case study. And I'm going to walk through some of the analyses and how to implement it today using Ethiopia as an example. And if you're interested in learning more about how we did it and what were, some of the inferences that we made from the analyses, please, you're welcome to go and look at our Ethiopia case study paper. And there are linked, the main paper, but also linked appendices that have tons of detail on how to do the interpretation and implementation. So let me walk into how we did this for Ethiopia. So there are 4 steps for implementing the decomposition analyses. Before I get there, I think there is some preparatory work that needs to be done to really prepare oneself for doing those types of analyses or undertaking those steps for the decomposition analyses. So let's walk through what some of those steps are. And just to recap here, the overarching question really was, what are the drivers and determinants of childhood stunting reduction? So the outcome here was childhood stunting that we were interested in Ethiopia, and the time frame was the year 2000 to 2016. So the figure on the right here shows the stunting trajectory in Ethiopia over the past 3 decades or so. And so you can see in the early 90s, stunting prevalence was, around 67%. By the year 2000, it dropped down to about 57%. And then between 2000 and 2016, it dropped down even more, about a third to about 38% or so. So there's about a third reduction that happened in stunting in our time frame of interest, the year 2000, 2016. And what we were trying to understand with this analysis was what contributed to that? What were some of the factors, some of the drivers, policies, and just general determinants that may have contributed to that reduction? So to do this, the foremost important thing really is to identify a conceptual framework, an evidence-based conceptual framework that helps you link out the variables and the various covariates and determinants, along a pathway or a conceptual pathway to the outcome. And so I'll show you that conceptual pathway in a second. And to feed into that conceptual pathway, I think it's important to get a sense of what data sets are available that can allow you to select those variables and analyze them further. For our exemplars work, we've focused on the DHS and mixed surveys for the most part, because these are the surveys that are available in, in low and middle income countries and that have the nutritional data that we're interested in. But you can also use other surveys, other non-standard surveys or subnational surveys as well that have various nutritional data. I think so long as it has data for the 2 time points of interest or the 2 groups of interest that you're interested in, looking at the differences between any kind of survey could be used. In addition to these national level surveys, data from other sources, so HMIS sources, surveillance systems and registries, and other available data sources could be included as well as ecological variables. So I'll talk about that a little bit more later on. For Ethiopia specifically, we were lucky in that there were DHS surveys conducted in the year 2000 and 2016, so aligned nicely with our time period of interest. So those were the main surveys that we used, and the outcome of interest, of course, was stunting or its continuous form height for HC score. I just want to point out here, even though the illustration we're going to show you is for childhood stunting or for HAS, really this method can be applied to any nutritional outcome, wasting, its continuous form, WHZ, anemia, or any other outcome, so long as it's available in the data sets. This is the conceptual framework that we used to organize our variables and our determinants. And you may recognize this framework. This is the usual under nutrition framework that's been published in the Lancet and the its predecessor, the UNICEF framework. So we've adapted it here for stunting. But essentially what we looked at were basic drivers, underlying drivers related to socioeconomic indicators, and then also how that influences more proximal underlying drivers such as household food insecurity and feeding practices, improved healthcare access, and then healthier household environment, and then how those influence immediate drivers or proximal drivers such as dietary intake and disease burden. And importantly, the intergenerational transfer of malnutrition piece, where we were able to identify proxies or variables for that, we've included those as well. So this is the general framework that was used across exemplar studies. For each of our countries, we took that framework, that conceptual framework, and turned it into a statistical framework, as I like to call it. And this framework is, takes that and maps out variables that are actually available in our data sets to the various domains in the conceptual framework. So we can see, where do we have good data, where are the gaps, and where are we going to be able to actually make inferences, meaningful inferences from the data available. So this is what the framework looks like for Ethiopia. So just a few things I want to point out here. The variables that are listed here were the ones that were available in the DHS surveys for the most part. And so down at the bottom, under socioeconomic factors or basic indicators, we looked at wealth index, maternal and paternal education. We, at least in Ethiopia and the DHS and from other sources, were not able to find good programmatic data for large-scale programs. However, if you do have that type of data for your country, you can include that as well. At the underlying level, underlying causes level, or the intermediate level, under the first subdomain, inadequate feeding practices and food insecurity, we used proxies of breastfeeding and complementary feeding, and importantly, a metric of consumable crop yield that we're able to obtain from other sources. Under inadequate care and health services, we had indicators related to vaccination, antenatal care, place of delivery, vitamin A supplementation, and total number of health centers and health workers in the per 10,000 population in the country. Under unhealthy household environment, we looked at urbanization, open defecation, improved drinking water, and household crowding. And under disease burden, we looked at diarrhea and ARI incidence. And for dietary intake, a range of different indicators that you see there. Of course, we were focused on the under 5 population for this analysis. And some of these data were only available for the 6 to 23 month age group. However, I've presented them here as the universe of indicators available for the under 5 group. So some of these, when we did the analysis for the entire under 5 population, may or may not have been available. Specifically, these dietary indicators. We also looked at low birth weight as a child characteristic and maternal age, adolescent birth, older mother birth, maternal BMI and height, and parity and interpregnancy intervals, all as sort of proxies of the intergenerational malnutrition transfer piece. Again, all imperfect measures and not, good to I'll say good to moderate level quality in terms of being proxies, but these are the data that were available. Just wanted to point out that the proxies and markers that we selected here were done with global experts and also country experts based on the unique stunting situation and what we thought were some of the key drivers. The crop yield and health worker variables did come from other sources, and we include them as regional level factors in the data set. And just wanted to point out again, this kind of analysis, even though we did it for the entire under 5 population, it could also be done for by age group. So for children less than 6 months, 6 to 23 months, and 24 plus months. And these are meaningful groups because their environment and diet might be different for these different age groups. Also, the DHS and MICS have some expanded modules, importantly diet and information for the 6 to 23 month age group that you could additionally analyze if you were to stratify by age group. So the analysis could be done really for either all these ways. And I'll show you our results for the under 5 population and the 6 to 23 month analyses that we did for Ethiopia. Just wanted to flash this up really quickly. We did do a quality assessment looking at how good the proxies were in terms of their missingness, how good they were as proxies of the phenomenon that they were intended to measure, whether we felt the quality was adequate. And so this type of quality assessment is important to do for any type of analyses, but especially for this analysis, because each one of these metrics or variables, it'll tell a story. And if the variable is flawed or inadequate, the story that comes out would be incomplete or misleading. So I think it's an important step to do this in tandem with a couple of analysts or researchers on the team, go through the variables available and assess their quality and how adequate we think they are for making inferences. I wanted to just talk a little bit about sample size. And so in the DHS for Ethiopia, there was a good amount of under 5 population. And so you can see here, in the DHS 2000, there were about 9,200 children, under 5 children that were alive. The ones that had available data, the ones that had available HAS data or high-free Z-score data specifically, reduced a little bit there, 8895. And then those that had valid data was about 8,565. And we did this type of assessment for all the surveys, just to get a sense of, what were the total, were the sample sizes adequate for doing this type of analyses? And really, I think if there were only 500 children with adequate anthropometric data, this type of analyses would not be useful and may lead to wide confidence intervals and unstable results. So we're up in the thousands. So generally that's quite good. So we do want to have the sample sizes that are higher, but also we want to ensure that the dropout is not too huge, because if it is, I think that there's an underlying problem in the way the data is collected and something that we need to be thinking about when we're making inferences later on. When we break that down by age group, you can see that so for instance, up here, the number of children under 5 that have good HAS data, good quality HAS data was about 8,565. Breaking down by age group, the 6 to 23 month age group has a couple thousand there, which is good. And the majority of the rest are above age 2 years. And there's a smaller sample, 800 or so in the less than 6 month age group. So this type of breakdown is also important because it'll, let you know whether you can do analyses stratified by age. And for Ethiopia, at least, this showed us that we could do analyses for the 2 subgroups, the older subgroups, but maybe not for the children under 6 months. If you look at the sample size, it's about 800 in the year 2000 and 946 in the year 2016, which is big. But as we start modeling various covariates, that takes away from the sample size every time covariates are added. So we do get finicky when we get into some of these smaller sample sizes. So I'm going to go into the steps of decomposition now. So that was the preparatory work, the conceptual framework, identifying the variables, mapping them back to the conceptual framework, making sure that we have enough sample size. And now I think we're at a stage where we can start thinking about implementing the methodology. So here's a snapshot of the decomposition analyses. There are 4 general steps. The first step is to do a series of descriptive statistics. The second step is to run regression analyses. The third step is to bring step 1 and step 2 together and apply the decomposition. And it's literally as simple as taking the estimates from step 1 and taking the estimates from steps 2, multiplying them together to get a product coefficient, and therefore you have decomposition. And then the fourth step is to visualize that data in meaningful ways. And so I will walk through each one of these steps in detail. Step 1. So for this step, the key thing here is to take the mean change or the mean level of the covariate and estimated for each one of the time points, and just to ensure that that's adjusted for survey design as well. The explanatory variables or the covariates could be continuous or categorical in nature. So for instance, you could look at a mother's years of education, and that's an example that I'd sort of carry throughout. But we could say in Ethiopia, okay, so in the year 2000, on average, mothers had 4 years of education, but in the year 2016, they had 7 years of education, and therefore the difference is 3 years. So that's the type of mean or mean we would be looking for. Or if it's a categorical variable, we could say in the year 2000, 50% of mothers had a primary education. In the year 2016, 70% did, and there was a 20 percentage point increase. So either one of those ways of expressing the covariate is fine for this type of analyses. So we would want to do that for the series of covariates that are identified as potentially being important that we've mapped to our conceptual framework. And once we've done that, we can assess the quote unquote importance of the variable, both based on both the magnitude of the difference and also the p-value for the difference. So let me show you what this looks like for Ethiopia. So this is a dense table, but I'm just going to highlight a couple of variables here. First, I wanted to show you up at the top that stunting prevalence in the sample, which I showed you before, is about 55% in the year 2000, and then down to about 37%. So we're trying to understand what drove down that change. The analyses we've done is using the continuous form of that, which is the height for z-score. So the mean level went down from minus 2.1, which is quite low, and improved about 1 standard deviation or so, or 0.8 standard deviations to minus 1.3. So it's that 0.8 standard deviation improvement in HAS that we are trying to decompose. Down here, I wanted to show you the mother's years of education. So in the year 2000, for instance, it was on average 0.88 years of education. In the year 2016, it was on average 2 years or 2.1 years. So there's a 1.22 years difference, which is a pretty big difference over time on average, and that is statistically significant. So when I do this type of analyses and create this table for each covariate, that to me would say, okay, the effect size is pretty big, and also it's statistically significant. So that would be a candidate variable that we could explore further. And the same for father's education. A couple other variables here. So here's an indicator that we included as a proxy of food insecurity. It was total consumable crop yield. And we can see that in the year 2000, it's about 11 quintals per hectare. In the year 2016, it improved to 18. So huge improvements there, and that is statistically significant. So again, from this assessment, I would say, okay, this is a candidate variable that we can include in the modeling. The total number of health workers also improved from 1.29 per 10,000 population in the year 2000 to 7.4 approximately. So that's a huge improvement, many fold, and definitely statistically significant. So again, this would be the type of variable we could move forward for modeling. So there are other examples here, and just in the interest of time, I'm going to move on, but I think that type of assessment could be done along the conceptual framework and the variables that we've laid out here to identify, which were potentially important variables to study further. So that is the first step, estimating the means, and then identifying the difference and really sorting out in your mind, okay, which are the ones potentially that are going to be important drivers that we need to look out for. The second step then is to implement the regression analyses. So here, because the outcome is child has, it's continuous, we can do a simple linear regression analyses, of course, adjusted for survey design, and it can be implemented in any survey, in any software, Stata, or any software that you're comfortable with. The equation is very straightforward for anyone who's done regression analyses in the past. It's just a simple, the outcome, the main covariate here, which could be, for instance, mother's education, looking at the beta that comes with that. A set of control factors would be included. So the control factors that we have put in our model were child age and sex. These are time invariant, and especially sex. And there could be other time invariant factors that are included as well. Just depends on what you think would be important confounders in your context to put into the model. And then importantly, putting in a dummy variable for your survey round to capture any trend effects. So creating a simple regression equation like this for each covariate, and I'll show you an example. I tried to put this in some simple terms here for maternal education. So for instance, If we were to do this for one variable, we could say the equation would be child has equals to maternal education, and the beta for maternal education is what we're interested in, or the effect size, plus child age, child sex, and survey year as control variables, and the error term. So we would do this type of bivariate. It's bivariate in the sense that it's looking at one covariate at a time and its impact on the outcome. It's not truly bivariate because we are adjusting for other things. But I think in the context of the analyses we're doing here, we could consider it bivariate as a one-to-one variable comparison. So we would do this for each of the variables that we looked at in step one as a further assessment of the effect size or the magnitude of the impact on the outcome and whether that was statistically significant. Just wanted to point out, when this is done, if you're looking at two survey time points like we did for Ethiopia, the year 2000 and 2016, there are options. What we did was pool the data set so that we had a larger sample size under the assumption that the beta coefficients for the covariates should stay the same over time. Sometimes that assumption doesn't hold. And so you could use just the last survey or just the earlier survey, and each one of these approaches could be fine. But again, one would need to do their due diligence in the data set to assess distributions and decide which one makes the most sense, given the way the covariates or their effect sizes may or may not be changing over time. So we did this for each one of the covariates at a bivariate level and implemented this threshold of a p less than 0.25 to determine those that were statistically significant, and that could be moved forward for multivariable modeling. So I'll show you one example here. This is for maternal years of education. So in the bivariate analyses, we found that the beta was about 0.074 with the confidence interval that you see here, and the p-value was statistically significant. The interpretation here is for every 1 year increase in maternal schooling, child has increases by 0.075 standard deviations after adjusting for the control factors. And that is statistically significant. So for us, when we were looking at drivers of stunting reduction in Ethiopia, we thought, okay, we know women's education is important to stunting. We see that there are improvements over time. We can see that the effect size is statistically significant, and it's a modest effect size. Therefore, based on all these criteria, this could be a variable that we select for multivariable modeling. I have another example here of health workers. So the number of health workers, doctors, nurses, and midwives per 10,000 population. The bivariate p beta or effect size was 0.032 with the confidence interval there that's quite tight. It was statistically significant. And again, this just based on the effect size, the p-value, and what we saw in the descriptive in step one, we felt that this was meaningful to include in the multivariable modeling as well. I wanted to show you one example of a variable that we didn't select. So ARI incidence within the past 2 weeks. This is a notoriously, tricky variable, poorly measured, not really representing the construct it's supposed to represent that well, lots of variation and seasonality issues. So, it's not the best variable, but we analyzed it anyway because it's really all that was available within the data sets. But what we found here is that, the bivariate, the beta was quite small. The confidence interval covered 0. The p-value was very large. So really the interpretation here is that there's no meaningful impact of this variable on child has in this data set in Ethiopia. P-value is really high, negligible effect size. So this variable was not selected for multivariable modeling. Similarly, we can do this type of assessment for each variable one at a time. Once we've identified the set of candidate variables, so those that have made it through our assessment, our earlier assessment, we can go ahead and do the multivariable modeling piece. So here, I think one of the ways of doing modeling to account for the conceptual, the conceptual framework and the fact that some factors are more distal, the more intermediate factors are, mediators of those distal effects and so on. So to capture the hierarchy in the data, we've done hierarchical modeling, which was published originally by Victoria in 1997, where he took each of these factors and did a stepwise modeling at distal, intermediate, and proximal level. So we did that with the data set as well. And here's just a simple, equation here. Essentially, the idea is for each covariate or each step along the way, we could fit equation 1 that I showed earlier child has with maternal education, child age, control factors, and then potentially other confounders. So it's the same equation, but expanded to include other factors. Just illustrated visually here, I wanted to show you what that looks like. So let's say we have identified, of the total 40 potential variables that were in our conceptual framework, through the bivariate assessment, we've determined the step 1 in bivariate assessment, we've determined that 20 of these are meaningful. And that's what remains in our conceptual framework. And say 3 of those are at the distal level. What we can do then is start at the distal level and implement the regression analyses. And I'll show you how the modeling is done. So we do the distal level modeling, and then to that distal level model, we'll add the intermediate level factors. And then to the intermediate level model, we'll add the proximal factors. So it's essentially a very simple regression analysis, but it's split up by level. And so that each of the factors at the various levels are modeled together, and that helps us account for confounding and avoid the mediation effect and overfitting the models with that, or biasing the models by including that. So just wanted to show you again that this is the conceptual framework that we are working with. The distal factors, the way we had organized them here, were those under the basic causes. So that would be wealth index, maternal and paternal education, each of which were important in our bivariate assessment. The intermediate level factors are here, underlying causes, and then the immediate were all clustered together as proximal level factors. So these were the 3 stages of modeling for the Ethiopia analyses that we did. And essentially, hierarchical modeling, as I mentioned, is quite straightforward. So at the distal level, we take all the variables, we put them into a model, do a backward elimination type of selection, and retain variables that are statistically significant at some liberal but not too liberal threshold, so p less than 0.1. And this is to allow, for the fact that there could be other confounders or unmeasured factors that we don't have in the data set that could be important at that level, and we don't want to be too stringent with our p-value in what we include. So it's a little bit of flexibility. This could also be a p-value of less than 0.1, just depending on your sample size. If you think the sample size is too large, it doesn't have to be as liberal as 0.15, but it should be something higher than 0.05. So at each one of these steps, we do the modeling, and just by the time we get to model 3, we have the final set of factors at the distal, intermediate, and proximal level that remain as being statistically significant. Just wanted to flag here, though, at each level, what we had done was a backward elimination type of technique for selecting variables, but really any appropriate methodology could be applied. Forward selection, best subsets. If there's another one that you have a preference, my suggestion is always to do a bit of a sensitivity check to see if the modeling approach that you use is going to really affect what remains in the model. Because if they're majorly different, then it becomes increasingly important to select, one methodology that you think makes the most sense for the type of question you're trying to answer. But really, any one of these could be options. And at every step along the way, of course, assessing the model with fit statistics, such as AIC, BIC, and residuals, and looking at collinearity between common variables is very important so that you don't overfit the models. So once we did this multivariable modeling exercise for the under 5 population for Ethiopia, this is what remained in the model. So at the distal level, we had wealth index, maternal and paternal education. So these were key drivers at the distal level that remained. At the intermediate level or underlying level, we had access to A&C visits, number of healthcare workers, total consumable crop yield as a metric of food insecurity, reduced open defecation. Those are the ones that remained. And just remember now, like the effect sizes of these variables are now adjusted for the distal factors as well. So they're adjusted for confounders even more so than they would be in the bivariate analyses. And then at the proximal level, we had diarrhea, maternal age, and then maternal BMI and height and interpregnancy interval remain in the model. So I wanted to do a simple interpretation with you for mother's education, which we saw earlier. So now that we've adjusted for other confounders in the model and done the multivariable modeling, it looks like for every 1 year increase in maternal schooling, child has increases by 0.04 standard deviation. So the effect is still statistically significant, but slightly attenuated because we've adjusted for additional confounders, and that's expected. Usually what happens when you adjust for confounders typically. And the same type of effect for additional healthcare workers. So the effects could be pulled out, effect sizes put into a table like this. And really, this is where we land in step 2. Now, step 3 is taking step 1 and step 2, as I mentioned, and bringing them together.
So maybe Nadia, just interrupting quickly, as we're seeing a few questions trickle in from Q&A that we might be able to tackle at this stage. Jennifer raised an interesting question just around how you account for changing definitions in stunting and covariates over time. So the example provided here for this question was, how do we account for WHO 2006 reference populations to calculate HAS versus prior to 2006? Or, as we're thinking about changing definitions, are there ways to sort of account for that for any of these individual sort of covariates?
Yes, absolutely. So we did encounter that, especially for the surveys that were done in the 90s. They were using earlier definitions. And so I think if you're able to, the ideal would be to take your macro, for instance, for, the new WHO macro, and apply that to the earlier data set so that you can get consistent definitions over time. And we certainly had done that in our analyses. So I think to the extent possible, if you have, you would need the micro data to do this analysis anyway. And if you have the original, height and weight measurements and age, you could take those macros and implement them and get the, commonly defined variables. I think a trickier thing to account for is whether the quality has improved over time, because that it could be that the info data in the 90s was not as good quality as it is now. And actually in some countries, we've seen that now it's not as good as it was earlier. So it's not always, it's not always the thing that it improves over time. And sometimes these things are volatile, but for anthro quality, at least, they are these anthro quality analyzers that are out there, automated macros that you can implement and look at and do a quality assessment really easily on your computer for anthro. Quality assessment for other variables is much trickier. And I think, as I mentioned earlier, that would have to be variable by variable basis, perhaps discussion among analysts, researchers, country experts to look at those variables and think about whether they're measuring what they're intended to measure. So I hope that answers the question. And just to say, for this analysis to work, it is absolutely critical for variables to be defined in the same way at both, at both points. So for instance, if we had ANC and the recall period and access to ANC, recall period was 3 years or 5 years in the 90s or in the year 2000, and now it's a 2-year recall period, these two are not the same. So it'd be tricky to look at trends in mean estimate changes in these variables over time because they're not identically defined. So it is critical for the variables to be defined in the same way as much as possible.
No, that's a helpful framing. I guess part and parcel with that, maybe just one other final framing question as we're thinking about sort of step 1 and step 2. We've talked a lot about variable selection. But looking at the outcome of interest as well, is there sort of a minimum amount of change required to apply this sort of method or any sort of guidelines around that might be worth capturing?
Yeah, absolutely. That's a great question. So for this method to work well, there needs to be change to decompose. If there's minimal change, then there's nothing really to break down. So the more change that's happened over time, this is relative change. The better the model is going to perform. So for instance, in Ethiopia, we saw that stunting reduced by about 1/3. And that's a good amount of change to try to decompose. In some of the other countries where we did this analysis, stunting reduced by 50%. So that's even more change to try to decompose. In terms of a minimum threshold, from what I've seen with model performance and when we did the stratified for different subpopulations, you would need at least 20% change, relative change, for the model to perform well. I have seen some published papers that have looked at 10% change, but they get very volatile, unstable results in their model. They still publish them to say, these are helpful and insightful, but not making any concrete recommendations based on those results. So my suggestion would be, I think a minimum of at least 20% reduction or change or difference between the two groups should exist for this model to work well. And the higher, the better.
Awesome. Okay, and then maybe one final question for this section before we keep things moving. Nikki had raised an interesting question here around sort of the consideration for categorical variables in which some levels are significant and not others. So, if we're talking about maternal education as an example, and we treat it rather than a continuous variable of years of education, as completion of primary, secondary, and tertiary.
Yep.
How do we consider that variable as either significant or not? Do we like keep one of those levels, or do we bundle it together? Yeah. Any thoughts there?
Yeah, absolutely. So I think the model works well with continuous or categorical variables. I think it would, to the extent where you can make binary variables, it would make the interpretation obviously a lot easier. Where you do have ordinal variables or nominal variables even that have 3+ categories, you can still apply the method. It gets a bit trickier, especially when some of the categories are significant and some are not. So the way the approach is done is you would still include that variable with its reference group in the model, and say, 2 out of the 3 comparisons to a reference were significant. When you go to interpret, like this slide here, and I'll get there in a second, the significant groups would show up here, but the group that's not significant would end up going into controls. Because it's important part of that phenomenon you're trying to capture, but that change in that subgroup is not significant to the overall story we're trying to tell. So we would capture it, put into a control as we do with other factors, and really here when we're illustrating the effect, it would be for those factors that have significant, those subgroups that have significantly improved over time. Anything else, Goutham? Should I continue on?
I think that's probably enough to keep us moving. In the interest of time, I think we can revisit some of these additional questions that are raised as part of the dedicated Q&A section.
Okay, wonderful. Okay, great. So here we are at step 3. Step 3 is applying the actual decomposition. So here we take the multivariable estimated betas from step 2 and the means that we got from step 1 and essentially just multiply them together. Super easy. And you could do that with equation 2, which is, we have the beta and then the difference in the means and multiplied together. And this would give us something that's called a product coefficient. So for instance, if we use that maternal education example, we would say that the change in HAS due to maternal education is about 0.041, which is the beta from the multivariable model, multiplied by the change in the mean numbers of years of schooling, which is about 1.22, and gives us about 0.05. So this is a unitless measure. In and of itself is kind of meaningless alone, but when we create product coefficients for all the covariates, it actually becomes meaningful because we can take these, we can rank them, we can add them up, and we can see, what is the relative change, what are the ranked drivers, and so on. So this type of product coefficient estimation should be done for all the factors that showed up in the final model and the final multivariable model. And then we can go ahead and start trying to interpret these. So I'm going to show you what that looks like. The screen seems to be frozen. There we go. Okay. So here is an example of the model for the under 5 children in Ethiopia for the time period that we were studying. So these are the same factors that I showed you in the earlier table that ended up being significant in the final multivariable model. So laid out in a table like this, we have the estimated coefficient from the model, and I've highlighted in red just some of the ones I wanted to focus in on. So we have the estimated coefficient from the model. This is the multivariable coefficient. We have the mean difference from step 1. And then we have the product coefficient here. So this is step 2, step 1 product coefficient. And then, what we can do with these, we have these, so these are unitless, let's say, parameters. So one of the things we can do is we can look across these and say, okay, which one has the highest value? And those would be directly comparable, and we can assess the rank. So for instance, here, it looks like total crop yield and healthcare workers have some of the strongest effects on HAS, our child HAS. All of these are significant, keeping in mind that, they remained in the model because they were significant, but the relative impact is different. So some of the other drivers that have a strong impact, not as high as healthcare workers and total crop yield, but still significant and notable are, reduced open defecation, mothers and fathers education, about 0.05. So significant but smaller effect. If we pull that together, it's about 0.1. So there's notable effect there too. If we add all these up, we can get a total, and then from that total, we can get the percent that each one contributes to the outcome. So it's literally as simple as adding them up and taking the product coefficient, dividing it by the total, and getting a sense of, what is the relative contribution or the percent contribution to the total amount of predicted change in the outcome that happens. And so if we do that here for this model, we can see that wealth index contributes to about 4% of the reduction, maternal and paternal education about 10% collectively, ANC, small but significant effect, about 2%, healthcare workers, about 28%, consumable crop yield, which is a very important storyline that was coming out of Ethiopia that we saw from our other work as well, the qualitative and the policy work. It definitely shows up here in the quantitative model, and it's arguably the biggest chunk, the biggest contribution here was improvements in food security. Reduced open defecation also had a huge, notable contribution as well, and then so did maternal BMI and height as markers of maternal nutrition or improvements in maternal care and nutrition during the ANC period and immediately post delivery in the first couple of months after that. So this is what it looks like for the under 5 children. Now, one other thing I wanted to point out, the model should usually add up to 100%. Sometimes I've seen in the literature and also in our own work that the model can explain more than 100%, and sometimes a little bit less. If it explains less, then what that would mean is that there are some important factors that are missing, and you might want to consider looking for those or trying to add those. Of course, if you've exhausted the set of data available, it's fine. If there's a chunk that's unexplained, you could explain that in a narrative way to say, okay, we didn't have data for X, Y, Z, and that could be what's explaining or accounting for what we weren't able to explain. That's perfectly fine. But sometimes you run into the situation where it's explaining a little bit more. And the reason why this happens is because there's a lot of different things happening at the same time, and it may be that theoretically, some variables improvement should have induced a certain amount of change on the outcome, but that didn't necessarily play out that way in reality. And so we see some change happening in has, and what this is telling us is that if each one of these variables contributed in the perfect way that they would have, according to the data, has could have improved by 20% more. But that didn't happen. So it's fine for it to go up a little bit. I think up to 120% explained. I've seen this done in the literature. You don't want to get a model that explains 140 or 180%, because I think that then there's problems in the way, the variables that are there. And we'd have to do a further assessment of the individual relationships and see which ones are accounting for some of these big changes. But I think just to be, because this is modeling and it's statistics and things are imperfect, I think we always have to allow buffer for thresholds. And I think, allowing for up to 120% explained should be fine and is justifiable. Now, if we implement this method for the 6 to 23 month population in Ethiopia, so we did it in the exact same way. I think the main difference here is that we were able to include those dietary intake variables that I showed you in the conceptual framework. We weren't able to do that for the under 5 population because they weren't collected for all those children. But here we were able to include them for just this subset. And we wanted to see, okay, did they show up in the final model? And so what we see here is that a lot of the same things are coming out. So the wealth index, maternal paternal education is being important. Breastfeeding comes out here too, as statistically significant, as one might expect. Place of delivery in ANC, again, as a the small but significant effect. The healthcare workers and crop yields again show up with some of the strongest drivers. Reduced open defecation as well. We wanted to specifically look at, or we thought that some of these dietary factors might be important. We were able to model them here, and it looks like the consumption of dairy products and fruits and vegetables, they had some significant effect, but it was really, really small. They remained in the model, but really it contributed in a negligible way. And I think this is when we get back, this is the point where we have to think back about these metrics themselves. Are the way these data are collected, are they the most ideal way to measure, consumption of dairy products or fruits and vegetables? And would we expect trends over time in the way these data are collected? So I think we have to be careful around the interpretation here. I don't think we're saying that dairy products and fruit and vegetable intake is not important to children 6 to 23 months. it could be just in this type of modeling exercise and the type of data that's available, it's not showing up. And that could come back to the way these data are collected and how valid they are for actually revealing a picture of dietary intake for the subgroup and so on. So just wanted to point that out. This is when you get into these kind of findings to really take these and think about what the inferences mean and do not mean. Beyond that, maternal BMI and height are pretty robust. Again, small but significant effect that is showing up in this age group as well. Okay, the final step here then is to take that and visualize it. And I think there's multiple ways of doing this. I've shown you some figures. I'm showing you figures here that we created in Excel. So this is super easy to do in Excel. This figure here is taking those product coefficients and putting them in Excel and ranking them, color coding them, in different colors so we can see the relative impact of the various drivers. Now, this type of visualization I think is useful because it allows you to assess really quickly what are some of the strongest drivers. All of these are significant, keeping that in mind, but what are some of the factors that are contributing the most, and what comes after that, and what's contributing about the same. And that's what we can see in this type of visualization. And again, these 0.31 unitless product coefficients are not in and of themselves that useful, but they're very useful to do this type of comparative analyses. And they're particularly useful, this type of visualization, when you run into some effects that come out being negative, and that happens, it's important to show those negative effects. And I can talk a little bit more later on, maybe during the Q&A, why that happens and what it actually means. So this is one way to visualize the data. Another way is to add up all the effects to 100%, like we talked about, or I showed you in the table, and really get the slice, the relative contribution slice. So for instance, for the under 5 population, total consumable crop yield explained about 1/3 of the reduction in stunting or improvement in HAS. The number of healthcare workers, another 1/3, and so on, contributions from various other factors. And then here is the illustration for the 6 to 23 month age group, again, presented in the same way. And of course, there could be other ways of showing this data as well. This is very simple and easy to implement in Excel. And it's quite useful really to make inferences. Now, the way that we have used this in our exemplars work, this is, as Goutham showed you earlier, this is one component of mixed method suite of tools that we used. And so we think, the whole story can't hinge around this one analysis, but this does help us tell a really neat multivariable, multidimensional story which we can, use to link other pieces back to. And that's certainly what we've done in our exemplar study. So here what I'm showing you is, and one of the other things we've done actually is now compared these findings across countries. And here I'm showing you for the other exemplar countries for the under 5 population, what some of the models showed. So you can see Ethiopia's models here. It explained more than 100%, a good contribution from various things. For Senegal, for instance, our model was only able to explain about 70% or so. And we had a chunk of unexplained here, and we had some reasons, we sat down with our country experts and other partners and talked through what we thought could be contributing to the unexplained. And importantly, what is the story for each one of these chunks, linking it back to the policy and the descriptive analyses and qualitative work as well. And then we've done this cross-country assessment, like once we have these for all 5 countries, what are some of the common drivers that are coming out across countries, and what does that mean for policy and action? Just wanted to point out that if it doesn't add up to 100%, it's fine. And I think we've talked about this before as well. So my last slide here, I just wanted to show you how this decomposition analysis featured in the broader story. And so we had these huge mixed method studies that were 300 pages of analyses and interpretations and so on, all summarized here into one slide. But this is the story that we pulled out for Ethiopia. There's improvements in household environment. These are some of the ways that it was done. Improvements in care and access to health services, improvements in food insecurity, and economic improvements and education and so on. And these are, the findings that came out from the policy work, the literature review, the qualitative inquiry. And importantly, what was neat for us is we could see how our quantitative results actually fit nicely into that story as well. So we didn't get anything that was wildly out of left field. Each one of these components, they fit into the broader story. And so we use these to help us narrate the story overall. It's one final slide on limitations. Again, these analyses are great, useful, informative, but they're imperfect. There are always limitations, and some of the limitations we've talked about throughout the session, but things such as availability and reliability of data. Sometimes important constructs, like for instance, food insecurity or dietary intake, are difficult to measure, poorly measured, not good data available. So we need to be thinking about those things, and especially where we identify proxies, are they good proxies of those phenomena we're trying to capture? The quality of the anthropometric data, we touched on this a little bit, is really important, especially with the changing definitions over time. So paying attention to that. Sample sizes can affect your modeling results, as anyone who does modeling would know. So always paying attention to sample sizes and the number of covariates per sample size kind of threshold. Applying that and just thinking through what's actually meaningful to do. And then large-scale programs, and I think, there are huge programs these countries adopt, whether they're the nutrition-specific programs or broad health sector programs or conditional cash transfer programs, and they do have sometimes a nutrition component or nutrition-sensitive component to it. It's difficult to assess their impact because usually they're not measured in DHS surveys, but even when they are, I think how we include those in the model and what it actually means, the metric that's available, I guess if there's no effect, it doesn't necessarily mean there isn't an effect. If there isn't an effect in the model, it doesn't necessarily mean there isn't an effect overall. I think these programs are complex and their measurement is challenging. So just thinking about that, we still need to think about these larger programs and when we're making interpretations and inferences, fit that in some way that's meaningful. Okay, I think that's all from me. So let me just stop there and thank you very much for listening, and I'm going to hand it back over to Goutham to walk us through how we've used these results in some of the policy and action work at Exemplars.
Awesome. Okay, I guess maybe, Nadia, before we dig in, there were a few additional questions that were raised that I think might be worth addressing now. I think maybe flipping back to step 3, if we can pull up sort of that table for Ethiopia where we've got mean difference, predicted change, and share of predicted change. Philip raised an interesting question just around this sort of step 3, especially for like younger children in terms of how do we interpret analysis. So the specific question here was just around the reduced open defecation. We're attributing something around the order of 15% of total explicable change among under 5 children to that specific metric. But how do we interpret that when we see that there's a large effect size, but it may not be significant? If there are any thoughts there.
So yeah, I think that's always an important question. I think, if it appears in this table, if it makes it to step 3, it's going to be statistically significant because that's one of the criteria for it to remain in the model. And then really it's about, the interpretation comes down to the effect size. But I think, if you see, for instance, what I've seen when I was in step 1, sometimes I've seen that some variables have a big effect size or a big change over time. So the order of magnitude is a 30% increase, relative increase, but the difference is not statistically significant, or it's not showing up as a strong factor in my step 2. Those are the situations where I would go back and think about, okay, is there a problem with the way this variable is measured, or is there a problem with with my sample size? Maybe, what is the issue that big change is not being picked up by the model? And that infrequently happens. So I think what I would say in that case is when that happens is to really, one of the things you could try is if the change is big, but the p-value is not statistically significant, is instead of using a pooled data set, as we've done here, we take the 2 years, put the time variable in there and model it, look at the p-values in that way. What you could do is just use one of the survey time points instead to get that, the beta and the p-value for the beta. And I think that's perfectly acceptable. And I've seen it done. And in fact, some of the reasons why people do it is exactly for that reason, that if you pull the data and the effect sizes or the beta is changing over time, it could be that the pool data set is attenuating the effect or masking the effect. And so, selecting one survey's beta, which you think might more realistically capture the relationship with the outcome, is fine to do. So I think that's one approach one could use. Again, I would say for now, doing these for multiple countries and different subgroups, that infrequently happens, but it does happen. And I think that's one of those situations where you'd have to do a variable by variable assessment and dig deeper.
Absolutely. And maybe just flipping to the slide right after this too, as we're thinking about interpretation of some of these effects and thinking through that as well. I think one of the challenges here around dietary consumption when we're looking at these metrics in particular is, even though there is a strong sort of estimated coefficient to your point, when there's minimal mean difference, right? When we're not seeing improvements on that dimension, it can show up as sort of smaller, relatively low portions of predicted change. So I think that's like the other challenge with interpreting some of this analysis as well, is not just, are we trusting the data itself, but are we seeing enough meaningful change on that dimension to have it be part of the sort of story of overall progress in any of these countries?
Yeah, absolutely. And I would say for the diet variables, specifically, I think these are just notoriously, problematic data.
Yeah.
It's the best we have, but especially for looking at trends over time, because diet is so volatile and is affected by seasonality. I think, like, for instance, if the Ethiopia 2000 survey was collected in the summer and then the 2016 data set was collected in the winter, would we expect there to be a trend, a meaningful trend in these dietary variables over time? Maybe not, because the diets would change with season in a country like Ethiopia and many others. And so then in this type of analyses where the data, the variable, the method is supposed to capture the improvement in the variable, it would not pick that up. That's just one of the issues with the diet variable. So just to say, I think some of these things we know, and we're actively working on trying to improve these in these multi-topic surveys overall. But I think the diet variables are a prime example of that.
Definitely.
And some of these other variables are much more robust, to changes to changing definitions or quality over time. For instance, like mother's years of schooling or father's years of schooling is a pretty simple, direct, straightforward question. Of course, it's prone to bias in different ways, but generally it's pretty robust, and looking at trends over time is acceptable and meaningful. And that's the kind of assessment one would have to do a priori, when you're in that preparatory work phase of this, like mapping variables out to the conceptual framework. I think if you're analyzing stunting as an outcome, the work that we've done already could be used as a starting point, all the analyses and the quality assessments we've done for variables. But for other outcomes, there may be adaptations you want to make or other proxies to add. And so doing that kind of assessment at that early stage becomes increasingly important.
Yeah, and I think that ties in well with this question that Tanya raised just around, challenges related to variables that fluctuate by seasonality. For example, like diarrheal disease, even components like wasting. Does that challenge or weaken the interpretation in the model, or is that something that we should be accounting for?
Yeah, absolutely. I think diarrhea and ARI incidence is another one of those. And I think the way to interpret this is, again, if it doesn't show up in the model, especially for diet and those like disease incidence type variables, we know that they have their own issues in terms of seasonality and so on. So I would say, we should talk about those in the narrative. And I think if they're showing up significant in the model, but with a smaller negligible effect, we can say, hey, look, the effect size or the impact based on the beta on the outcome is X. So there is a meaningful impact, and we can see this in both survey years. However, the change over time is so tiny, which could be due to X, Y, Z, and therefore we're not seeing it show up in the model. However, that doesn't mean that it's not important. It could be that if it was measured better, or that if it was measured at the same time, seasonally in the two time points, we could have seen more of a overall change and a bigger impact. So I think that comes down to making sure those things are highlighted in the interpretation and the inferences that are made and not masked. I think we have a tendency to like focus on what's significant and hide everything else in general in research, but that's not the approach. I think that would really lead to misleading stories. So in this type of model, you can see we've left in things that were significant, even though a negligible effect, because we do think there's a story to tell. Whatever that story might be, we can unpack it with some of the things that we talked about.
Yep. And then maybe one final question for this section before we dig into commentary and then Q&A. There was a question raised just around like visualization, the challenge with visualizing an analysis like this.
Yeah.
If we're going to something like the stacked bar chart that we have on slide 54, one of the challenges with this is that when we're looking at the final indicators or the list of sort of contributory drivers, it's easy to like look at this and say, these are the only variables that could contribute, right? So as we're thinking about this analysis, or if there are any thoughts on your end, just in terms of, are there other variables that have a significant impact that are missing from this analysis? Is there like a way to reflect that in some sense? Or is there value in doing so?
Yeah, I mean, I think in our work, in this particular figure, it's difficult to reflect that because this is just a figure that shows relative contribution from what remained in the model. But I think the way to shed light on that again is in the narrative that accompanies this figure that goes into your paper or report, to make sure those things are discussed up front, especially if you know from other work. So for instance, in our case studies, we would know, we would see in the policy work or other literature reviews that some phenomenon is really important, but the DHS didn't capture that very well, and therefore it didn't show up in our model. We would make sure that we address that in the narrative and talk about that and what we thought the impact could be. And it could be that, so for instance, this in Ethiopia, there's 32% contribution that's happening from improvements in health workers. This could have a story of its own. Is it really just about the health workers? The marker we had was health workers, but what are the health workers doing? And what interventions are they providing? And what are the system level factors that enable them to get access and reach people? There's a whole story there that could be unpacked, and that should be unpacked when we try to break down what that 32% means. And that's what we tried to do, in the Exemplars work when we triangulate these analyses with the other activities. Is we're not just saying, well, get more health workers and you're going to reduce stunting by 30%. No, there's a whole story and a pathway of how that happened leading up to the health workers. The policies and the actions that were taking place to make sure the health workers were trained and deployed, and then actually working in their field and what they were providing. There was a whole story there that we had to unpack, and a lot of those variables are just not available in the surveys, and so therefore they don't pop up as individual contributions. But so just to say, like, I think there's those kind of other dimensions or metrics could be captured in the story that we tried to tell for some of these big contributions here.
Yeah, I think the only other thing I might tack onto your answer there, Nadia, is just looking at these bar charts too. There are significant portions of these sort of components of change that we're trying to explain that remain unexplained, right? Mm-hmm. And I think that's fine. That's still part of the value of interpreting this analysis, is to be able to say, like, this is the portion that we can explain, and this otherwise sort of unattributed portion that remains unexplained might be due to sort of challenges in incomplete data.
Yeah, absolutely. And then we could try to explain it, bringing in some evidence from the, in our mixed methods work, for instance, bringing in the evidence from the qualitative or from the policy work, for instance.
Right, and or sort of other complementary data sets, right? Beyond sort of mix or DHS, if we want to work with MIS data in any capacity. All right, well, in the interest of keeping things moving, why don't we dig into the commentary section? Okay. I'll do my best to wrap up here.
Okay.
Yeah, so I think there were a few questions raised just around the Q&A around how do we use this? What does this mean in terms of implication for policy? And what's the value of this particular piece of evidence or analysis as part of the broader sort of interpretation of the mixed methods work? So I think, if we're looking at the Exemplars work and these decompositions as part of the framework or the sort of final recommendations coming out of it, it was really useful in identifying common themes, right? And so while each of these bar charts look pretty materially different, on a country by country basis when we're looking at this analysis, there were sort of powerful trends that it helped us identify at a higher level, just around sort of nutrition sensitive versus specific relative contributions. And it was a clear story to be able to communicate to decision or policymakers in country to be able to say, these components matter to this degree and to this extent. And so I think, if we're flipping to the next slide here and digging into like what that means in practice when we're looking at these illustrative charts on the next slide, we've seen this sort of chart on the left-hand side here before that Nadia showed, describing sort of each of these component contributions to total explicable change in Peru, the Kyrgyz Republic, Nepal, Senegal, and Ethiopia. And then once we start bundling these into sort of macro categories of direct and indirect health and non-health sectors, we begin to see this sort of pattern of contribution of, where if we describe the health sector, direct and indirect, as roughly mapping to nutrition specific interventions, we're seeing a roughly 50-50 contribution of these components. And so while that's sort of in line with existing evidence, it does help in terms of communicating why certain components matter or if they matter at all. One example of this that comes to mind is certainly the story around improved wash practices, right? Whether we're talking about open defecation or just general improvements around access to piped water or improvements in sanitation. I think there was a lot of confusion around that, especially in light of sort of RCTs like the Wash and Shine trials in terms of, does this matter to stunting? Does this matter over a 10, 15-year time period, even if we're looking at really robust, well-designed RCTs in the 2 to 5 year time period? And so this is one way to take a look at that from a broader time scale and begin to understand if we think this still matters to stunting, trying to understand what the relative contribution is and in what sort of context it may make sense to still be mindful of investments in that space as it relates to sort of generating or designing a broader sort of multi-sectoral nutrition strategy. So all that to say, when we're using this analysis, it's one component of a broader set of mixed methods work, but this is one way to really communicate both the multi-sectoral nature of addressing stunting successfully and the need to do that in a comprehensive way to address each one of these components in order to sort of replicate the progress that we're seeing in these exemplar countries. And so on the next slide here, we can dig into some of the key takeaways when we're thinking about what does this mean in practice? What does this look like when we're talking about trying to give prospective guidance to in-country decision makers? So we talk a little bit about phase one. What does this diagnostic look like when you're thinking about applying these lessons or learnings in practice in your own country? And so here, there's a real story to tell around making sure that we're building a strong evidence base in order to understand, begin to sort of diagnose the true nature of burden in country, and therefore, by extension, determine which of these factors that we're identifying in some combination of these decomposition analyses, a number of other descriptive quantitative analyses, and the qualitative work may be most applicable for the specific context in which policy and decision makers are trying to move the needle on stunting. And then in terms of sort of key metrics or key investment spaces that are going to be particularly important, sort of steps 3 through 10 here, both within and outside of the health sector, were really dimensions that were called out pretty explicitly as part of looking at this set of decomposition analyses across countries. So again, sort of understanding that this is the sort of meta interpretation of a number of these discrete analyses in terms of informing final recommendations around nutrition stunting strategy. And then the final piece here on this next slide is sort of mapping this back to policy and decision-making sort of timeline reviews that we did on the qualitative side of things, along with a number of focus group discussions and discrete quantitative work to begin to understand across each of these dimensions that seem to emerge consistently through the quantitative decomposition work as meaningful or worth exploring. What's the real story around the investment strategy in country against each of these dimensions. So to Nadia's point, with the example in Ethiopia, where we're seeing, something on the order of 32% of explicable change being attributed to improvements in health worker sort of coverage. What's the real story there around investment? Is this in the case of Ethiopia, it was both a dedicated investment in the health sector sort of extension program. So really having that CHW push in order to get coverage, but there were a number of additional sort of complementary policies and programming components that were worth calling out explicitly in terms of how that investment was made. And a lot of that story, which is really captured in the mixed methods approach, is what we aim to capture as part of the broader narrative and in the full sort of 300-page report, and of course in hopefully the more digestible version, packaged up findings that exists on the platform. And so maybe that's a nice way to sort of wrap this up on the final slide here of 62, which is to say, a lot of these, a lot of the like final output for this goes well beyond the decomposition analysis alone. And so a lot of that work you can find on the Exemplars platform itself. Encourage anyone who's sort of interested in digging in a little bit more into both how these results are being used in practice and sort of what these results look like all pulled together beyond sort of the decomposition work itself, to go check it out on the Exemplars platform. But with that and with an eye on the clock, maybe I'll pause here and welcome some additional questions or thoughts from folks, if you want to drop them in the Q&A. I think just digging through questions that we're seeing now, there was a question here that I think is interesting, Nadia, for us to discuss. There's a question raised just around the need to rethink the way we're looking at stunting as an outcome in general, or whether it's sort of an appropriate metric or measure of undernutrition, and what the implications of that are for our work more broadly, and then maybe specifically as we're thinking about this decomposition analysis.
Yeah, so I can start with that. I think that's a really important point, and certainly a topic of debate in the field in the past couple of years. What is stunting actually capturing? And so in our work, I think there's two things here. There's one, stunting, which is the dichotomous, categorization of has at the extreme levels. And so using stunting as opposed to has, it only captures the most extreme and maybe not people who are on the threshold. So in our analyses, what we've tried to do is use child has where possible, so that we could look at the continuum of, z-scores in the population as opposed to just the one group, which again is limited in varied ways and mostly in the way it's defined. But I think that doesn't, so that's what we've tried to do statistically. And still, we've run these models and we're able to see contributions from various things and use the mean has as the main outcome. But I think that doesn't get at the main point of the debate, which is stunting a real thing? Is stunting, does it exist? Or is it really, this is just a marker of an accumulation of various things like poverty and deprivation at the population level or at the community level, and it's like showing up as this marker in children, but perhaps it's not an undernutrition phenomenon or outcome in and of itself. And I think that's the debate that's going on. And I'm not sure, our analyses are not designed to answer that question. I mean, we can take the data that's collected and try to say, okay, if stunting, or child has is a marker of let's say nutritional deficits in a chronic way, we can try to look at what the drivers are. So our analyses can do that, but I think the bigger debate about what that means is still something that's up for discussion. And yeah, I don't know. I mean, in our work, we try to say, these are the drivers, and we think that if countries take action, for instance, in improving maternal education or WASH or whatever, these are the kind of changes we could see to the stunting metric or to the stunting phenomenon overall. And we try to root our interpretation in that way, but I think we haven't. The other debate is something that we haven't really gone too much into. I don't know, Goutham, do you want to add anything to that?
Yeah, no, I mean, I think you covered the real meat of it. I mean, I think there's always this sort of debate around, is it the fire alarm or the fire? I do think, when we're looking at our quantitative analysis in particular, part of what helps with this too is the distinction between the definition of stunting versus linear growth restriction more broadly, right? So looking at the continuous variable of has, I think, helps with some of that interpretation of just saying that it's not just about reducing stunting as a specific outcome. It is about more addressing linear growth restriction and identifying drivers that drive improvement on the sort of continuous dimension as well. Yeah. Awesome. Well, I see we're sort of bumping up against time here. Maybe a few other questions that might be worth addressing. I think Nikki in chat dropped a question that I thought was interesting. When we're thinking about this analysis, how does this inform nutritional programming and nutritional measures? Just thinking about maternal education versus, for example, maternal nutritional education, or how we sort of capture that nuance in either this analysis or sort of our broader work in exemplars.
Yeah, so I can start with that. So this particular analysis, the variable that was used is just what was available and collected over time between the two time points. So it was, the mother's years of schooling. So that in and of itself is a measure of how many years of general schooling she's had, and not necessarily nutrition focused education. But I do think that there's, if that has improved over time, one through in our case studies, for instance, what we've been able to do is if we see that there are notable improvements in maternal education over time, and that it's an important driver, we could go to policy and action and other interventions that are, focused on nutrition counseling, for instance, in the prenatal period, or for mothers in facilities or wherever it might have happened in that country, and try to build out a story related to education. So if she had improved her education, there's a chance that she may be accessing health services or, receiving these other interventions. And we can look at coverage of those interventions and improvements in those areas as well to try to build out or flesh out this more nuanced story around maternal nutrition counseling or education. And unfortunately, in the DHS surveys, that type of data, maybe the more recent surveys are collecting it, but the earlier surveys didn't have it. So we couldn't quantify its impact as we were able to do with general education. But that doesn't mean that we can't still narrate a story. And I think like improvements in general education are a good marker. And if we see that in the storyline, I think it's a good indication that it's worth pursuing further and trying to see where there may have been improvements in other, more focused education initiatives. And especially, if there are huge behavior change campaigns or, maternal nutrition counseling campaigns are happening at the household level, maybe, or at the facility level. And we know that those are active in the country. In our case studies, what we've been able to do is go through and again, unpack those, even if it just started in the past 5 years. And for instance, in Ethiopia, it didn't exist for 16 years, but did in the past 5 years. We could say recently, there are these initiatives that have been happening to improve maternal nutrition understanding and so on, and try to narrate a story along that. Again, we might not have the percent contribution of that or that nice number to tack to it, but triangulating with some of the other activities, I think we could still build out a story. Goutham, did you want to add anything to that?
I mean, the only other thought, maybe just like at a high level sort of conclusive statement, is all models are wrong, but some models are useful, right? I think like when we're seeing something emerge as a factor, this is, I think, the value of using the mixed methods approach too, is being able to think about, can we lean on the qualitative work a little bit as well to help us interpret some of this analysis? If we're seeing something like maternal education emerge, going back to understand what exactly is access to additional years of education actually providing in terms of the mechanistic pathway that may affect stunting outcomes in general. So just like another reminder for us to think about, this being one component of a broader set of analyses to inform sort of a narrative in that sense. And maybe a nice conclusive statement to end on, but I'll pass it back to Rebecca here to wrap us up.
Great, thank you. And I just want to say thank you to everyone who was here in real time, also for those who might be watching this in follow-up. I want to give a special thank you to Nadia and to Goutham for really laying this out for us. This was kind of a new webinar for us to do a deep dive into an analytical method that's being used, to understand things. And we would welcome, if you have other, analytical methods that you'd like to understand more, let us know, and we could see if we could get some of the people using them to do something similar, because we really just want this to be a tool. So please encourage you to share it, share the link. And we also will be, so there is a recording of the webinar that's available immediately afterwards to the Data for Nutrition YouTube channel. And we will be, posting the presentations and summary on the community of practice. So thank you so much. We hope you enjoyed it, and we hope to hear from you. Bye-bye.